Thank you again for joining us again. So I will start off by just giving a brief update on the numbers, and then I'll pass it on to Rachel to talk about vaccinations, and then Dr. Cohen will give us a perspective from the hospital and clinical side. So as of this morning, we have 102,793 cases of COVID-19 that have been reported to Sacramento County, and 1,663 deaths. Daily case count has dropped. It's 122. If you recall, the last time we talked, I told you that it was about 150, and now it has started to drop. The case rate is at 7.8 per 100,000. We have been in a plateau for quite a while, actually, the whole of April. Our numbers have been about the same. And so we unfortunately did not reach our aspiration of getting to the orange tier by the end of April. But now that the numbers are beginning to drop, we have hope that we will be able to achieve that with this coming month. And actually the last 2 days, our numbers have dropped below 100 cases daily. So we're hoping that that will continue. According to the state blueprint, we are still in the red tier, and the state blueprint, which is there's a 1 week lag in their case count. We are at 8.4. So, but again, looking at our dashboard, you can see that we are trending downwards now. So that is a good sign. This week, the CDC did release additional guidance for people who are vaccinated, things that they are able to do. And of course, the one that's highlighted the most is that actually now for people that are fully vaccinated, they are able to engage in activities outdoors without wearing a face covering or a mask. So hopefully that encourages some people who are still on the fence about getting vaccinated, that there are additional things that you're able to do. And of course, there are additional guidance as well for things that you can do if you are vaccinated. So for our vaccine update, I will turn it over to Rachel.
Hi, thank you. My little dog is having a fit over here, so so be interesting. Thank you for having me back. I'll just go over the numbers for the vaccine allocation that we received this week, talk a little bit about bringing back Johnson & Johnson and what we've been doing at Public Health. So this week, Public Health and our partners received, or for next week, we will receive 22,430 doses of COVID vaccine. That's 10,530 doses of Pfizer and 11,900 doses of Moderna. And we did not receive any Johnson & Johnson vaccine this week. And this is a pretty similar number to what we've been seeing over the last few weeks. And then you, I'm sure, have seen in the news that the CDC did lift the pause on Johnson & Johnson vaccine, and CDPH has supported that lifting of the pause, and we're following that guidance. So we will be bringing Johnson & Johnson back to some of our community-based clinics as well our partners. It's a safe and effective vaccine, and the benefits outweigh the risk. We are, however, wanting to make sure we're very careful about our approach, and have made a decision that we do want people to be able to have a second vaccine choice. If we're at a clinic with Johnson & Johnson, our goal is to bring a second vaccine if there is someone there who is uncomfortable with taking that vaccine. We did a few weeks ago, our team pulled out of Cal Expo. It's still being run by a partner. And so that's really helping us be able to consolidate our efforts to work in the communities more. And that's where we know really the work is yet to be done and continued. And so working with community-based organizations, doing pop-ups, and then we do continue to do outreach to people experiencing homelessness and the homebound as well. And our website has all the links, of course, to appointments, and there's definitely appointments available this week. So hopefully everyone who's been looking for a vaccine appointment was able to get one this week. And I think that that's it for my update.
Great. And Dr. Cohen?
Hi, so I'm Stuart Cohen. I'm the Chief of Infectious Diseases over at UC Davis, and I appreciate that people keep asking me back to participate. And it's always interesting listening to Dr. Kasirye's update, because exactly what she said is reflected in the hospital. We have been stuck on a plateau for probably 2.5, 3 weeks, but we've noticed the last couple of days there has been a dip. And the number of patients is almost half as many today as it was on Monday. And in general, the patients have not been quite as sick. We haven't as many people in the intensive care unit as in prior times. And I think that one thing that sort of gets a little overlooked in the discussion about vaccines, which is what we're going to talk about pretty much for the entire time, or at least that and masks. I think the treatments have gotten better. And so the availability of the monoclonal antibodies has kept people out of hospitals. And I think all of our physicians, particularly those in the critical care units, have gotten just much better at managing patients. At the beginning, everyone was worried about potential patients potentially aerosolizing virus, so they intubated patients faster than they might have otherwise. Now they don't have to. And so I think that's keeping people out of ICUs. So, you know, you would hope that we would learn something over a 14-month time period caring for these patients. And we have, and I think there are therapeutic options. They're still not perfect. We'd like things to be better, but we are a far cry from where we were at the beginning. And I do start sensing that we're starting to actually see a drop here in Sacramento, which is terrific. That's what we're all looking for.
Great. Thank you, Dr. Cohen. All right, so we have some really great questions coming in. So let's get right to those so we can answer as many as possible. So we have quite a few questions about the Johnson & Johnson. So we have a community member that says, I work with unhoused communities. What advice would you give to calm people's nerves around Johnson & Johnson, since we're going to be using it again?
So I can speak in part to that. We've had similar discussions in the University of California system. All the campuses, we've been discussing how to look at the J&J vaccine. And I think that we've moved to the same idea that the county has, which is people can opt out if they don't want the Johnson & Johnson, or they can opt in and say that's what they want because they are interested in just getting a single injection vaccine. As Rachel brought up, it is a good vaccine, but there is a higher risk with this vaccine than the other two, and we have to be open and upfront about that risk. But if you look at the data that was submitted to CDC, the risk for women under age 40 is about, or under age 50 is about 7 per million get these clots. And if you break it down further, it's about 11.8 per million for women between 30 and 39. And there's recently been a man hospitalized at UC San Francisco. And so it's not all women, although it still is pretty much high risk. And so I think if you talk to people and give them an idea of what 7 in a million means, which is similar to getting hit by lightning or something along those lines, I think people can make reasonable decisions. And so I think it's important that we talk to everybody about this. I think, you know, nothing's ever perfect. But in this circumstance, if there are people in particular who don't think that they can show up for second doses, I think that this is a perfectly reasonable strategy to address this problem.
All right, great, thank you. Well, we'll have plenty more questions about J&J for everybody to answer tonight. So we have another question about J&J. If you had the Johnson & Johnson, can you eventually change to get Moderna?
You know, that's a question that is actually going to be answered, and it's going to be answered regardless. It's not just going to be J&J. It's going to be, can you end up getting a booster with a different brand than you got your primary series? And the National Institutes of Health is actually starting to do a study with crossover vaccines. You know, we don't think about what brand of flu vaccine we get each year. And so ultimately, I think that this is going to be the situation. We have to demonstrate that it's safe. And so the studies will be done. And I suspect if I were to have to hazard an educated guess, I would say, yes, the answer is you surely would be able to.
Thank you. All right, one more Johnson & Johnson before we pivot to another subject. Any thoughts about only giving Johnson & Johnson to men and women over the age of 50?
Yeah, that's a great question. I actually did think about that, and I was wondering whether the ACIP, the CDC's vaccine experts, would actually put that in as a potential caveat. But so I do think that younger women in particular are higher risk. And so I think that you can weigh that when you talk to people. And if it's an older guy like me, the chances of a clot right now, based on data, is zero, because there haven't been anybody my age that have had clots that are men. But you know that zero is not really going to be zero. And so, but it's pretty darn close. So I think that kind of stratification is part of the discussion that you have with patients, to be totally transparent about how things are going.
Great, thank you. Okay, let's pivot to masks. So, you know, as you all mentioned at the top of the conversation, there's been some changes and guidance around masks. When do we anticipate removing the mask mandate indoors for people who are fully vaccinated?
We don't know yet. We are dependent on the CDC to provide us with that guidance. I think we need to continue to see a drop in the cases and case rate, because the more cases that you have, the higher the chances of infection. And so we just need to continue using the same measures that have been very effective in keeping people safe. One of the questions that I thought that was going to be asked was, when is California and Sacramento going to change our masking mandate? CDC has told us that, the CDPH, that's the state, has told us that they are working on updating using the new guidance that the CDC put out. But because the masking mandate is linked to a lot of additional guidances, they are still going through the process of updating all of the different documents before they release it. So I'm hoping that it will be soon, but we don't have a date yet as to when that will happen.
Thank you. So just to make sure we're clear with the community, essentially there's been this change at the national level, And we're still figuring out, the state is figuring out then how that applies to the state and then locally. So folks should hear soon about how that might apply to Sacramento.
Correct, yes.
Okay, great. And so that also addresses another question that somebody had about what does the limited mask usage mean that the governor mentioned? So thank you for that question. So another question about masks, people with or without an experimental vaccine can go outside with or without a mask. Why are you all promoting a vaccine passport?
There have been some discussions about vaccine passports, but at this point, there are no decisions that have been made. The guidance that we have from the state does include different levels of, for example, for events and indoor activities. It does include guidance on different capacities based on whether individuals that are attending are vaccinated or not. But there is no, at this point, no passport that has been created. What the expectation is that you would use the CDC card that you get when you get your vaccine.
Got it. So Joshua works for a local homeless shelter provider and is noticing a lot of vaccination hesitancy among not just their homeless clients, but also staff. What resources can be provided to help better educate our staff and clients to encourage them to get vaccinated?
We're doing a lot of outreach and working very closely with service providers who work in those communities. For example, you mentioned the homeless. We do have teams that are going out and doing that outreach. We have nurses that provide education. We also have, as members of the team, we have physicians and other clinicians that are available to answer questions. So basically just having that one-on-one, being able to talk to people, finding out what their concerns are and answering their questions and giving them the reassurance. And then what we found in some of our earlier outreach is that sometimes people who are hesitant said, well, I'm going to wait. If other people are going to take it, then I'll see, maybe the next time you come around, I'll take it too. So the more people that get the vaccine and are okay, the more encouragement that gives to others as they see that, you know, it's okay to get this vaccine, nothing bad is going to happen.
Yeah, I just like to reiterate that. I think first, how many million people have already been vaccinated in this country? And even with the Johnson & Johnson, that's a very limited number of people with all the vaccines that have been delivered that have been associated with any significant side effect. And so, but you have to be able to answer people's questions directly. I do this when I see my patients. If they can't really say why they're hesitant, it's really difficult to counsel them, particularly if they're younger, and the chances that they really will end up getting severe disease is pretty low, albeit not zero. And so you'd like to be able to get your arms around something that you can really discuss, because we have a lot of data now. There have been an awful lot of people vaccinated.
Yeah, and I also want to add, I know this is a term that is being thrown around quite a bit lately, trusted messenger, but it is important. What we have found is sometimes, as Dr. Cohen has mentioned, that a person cannot really put a finger on why they're hesitating, if it's really due to hesitation. But because they you know, there's a lot that's been floating around in social media and also things that they hear. And so they're not sure. But what we have found is if the message is delivered by people that they are already accustomed to hearing from, or people that they trust, that it it makes that difference. And I'll give you an example. We were in a meeting talking to some community members and asking them about, whether they were planning to get the vaccine or not. And one lady turned to us and said, I trust my pastor. If my pastor tells me it's okay, I will take it. So it was as simple as that. It wasn't to do with any of the facts that we were presenting to them, but she just wanted to hear it from somebody that she trusted.
Thanks, Dr. K. And so, yeah, we actually have a question about trusted messengers here. Thanks for breaking that down for us. And this community member says, today's Sacramento Bee talks about using an intersectional lens. What does that mean?
I'm not quite sure because I don't know what article they're referring to. So not sure how to answer that one.
Mm-hmm. Yeah, so I think that I think I actually saw this article, and it was talking about the intersections of race and gender and other kind of areas that go into how we think about providing vaccine education. So thinking about things in an intersectional way.
Well, what I can say is that as we've been thinking about our approach to doing more outreach, and I would like to give an opportunity to Rachel as well, because she's been an integral part of these discussions, is that one thing that's clear is that, yes, with the larger throughput sites, the drive-through sites, people who have the means and are motivated were, availing themselves of those appointments. But we knew very well that, especially also looking at our data, that there were some people who were not getting that access, even when the eligibility was opened up to everybody over the age of 16. And so we needed to go to those communities and find out how to do that outreach. And one of the ways that we found that has been very effective is, in some situation, the community-based agency, they go door to door and actually sign people up. And they'll call them, hey, you have an appointment today. You said you were going to show up. Where are you? So it sometimes it gets to that level where you really have to do more to actually get people to actually turn up for these appointments, as well as, of course, making it easier with transportation and location. And, Rachel, if you'd like to add more to that, please.
Sure, I would just reiterate that when we started these efforts, mass vaccination was the way to get this vaccine out the fastest, and we were looking at occupation-based sectors as well. So people that we felt like would probably have transportation to the site, and we're continuing to operate those and will as long as there's good throughput. But we do recognize that we have to continue. We've been out in the community, but we want to make sure that we pivot and really have more opportunities for community members to have the vaccine offered in their neighborhood, in their community, at their church, like Dr. Kasirye said. And we know that some folks are going to be more willing to take it. And it's also, if transportation is an issue, then they're able to, walk or get to that site. And we approach flu the same way every year. Our public health, I would say, supports the flu efforts of all of our providers by making sure that flu clinics are held in communities that have access issues or are hard hit by flu. And so this isn't anything new to us. It's just it's a very broad scale. We're going to go out and do as much of this as we can, but this is really the heart of what public health does, is reach people who need assistance, with, and in this instance with COVID vaccine. And we do want to use people in the community that are trusted by that community to both offer the vaccine and to encourage that message.
Thanks, Rachel. And actually, there's a question that builds off of that. So Martin was wondering about our strategies to support low-income communities. And Martin's wondering, there are many pop-up clinics that operate on weekends or a couple days a week. Has there been a push to have larger 7-day-a-week vaccination sites in South Sac or North Sac, similar to Scottish Rite?
Yes, we have discussed that. The clinics that are run by the county, and actually right now we're focusing more on pop-up clinics. Some of those are on the weekend, but some of them are weekdays. But we are in discussion of being able to have one that runs 7 days a week, but it's a matter of finding the site that will be the best for this, as well as making sure that we have the resources and the vaccine.
Got it. So there's one question from Andrew that I'm gonna ask here, and then we're gonna switch over to some folks that are interested in Pfizer. So Andrew is wondering, can I get a shave or a beard trim if both my barber and I are fully vaccinated, and how soon? This is, he's looking for his beard trim sooner rather than later, it seems.
I did it. Right? Can't you tell how trim I look right now? It's absolutely.
You got the answer from someone who's done it.
Okay, there we go. Good thing we have somebody on the line who's also had a beard trim. This is great. So the next question we have is, a family member is bummed after being advised by her doctor not to get the second Pfizer shot due to an extremely rare side effect, decreased platelets. Have you seen this side effect? Bleeding, not clotting.
Yeah, well, that's an interesting thing. I'm going to try to make this reasonably understandable. So first off, the clots associated with the J&J vaccine also are associated with low platelet counts. This is it's a combination type thing. So even though we think when people have low platelets, they're likely to bleed, in that setting, it is different. It's similar to what we see with a drug called heparin that we use as an anticoagulant, where there's a production of an antibody that makes the platelets go down and also increases the risk for clotting. It is unfortunate. It has been reported. It's a rare effect. I think I saw somewhere today that the number of people who have had severe or even moderate side effects with the Pfizer vaccine is under 15%. And so it's pretty uncommon, and the really severe side effects are way lower than that. I would venture somewhere under 1%. So, rare things happen rarely, but they happen.
Got it. And so what happens if you, Gwen's wondering, if you did only take one dose of the Pfizer and you can't take the second dose, what does that mean for me?
Yeah, well, that's not totally clear. Obviously, all the studies were done with 2 doses of vaccine, and it did appear from the initial data that were presented to the FDA that after about day 14 of the Pfizer vaccine, the rates of new cases of COVID-19 had decreased quite significantly and almost to the level that they would with 2 doses. Now, whether it's going to be durable or not, and whether there is more likely risk to get infected is not clear, because that really hasn't been studied. In Europe and in Canada, they're separating the 2 doses by much more than we do here, and much more than the manufacturers recommend. because of the fact that it appears that that single dose will hold them for a while. I don't know what a while means, but I think that, you're protected for a bit at least.
All righty. So we have some questions about vaccine supply. How are we dealing with the smaller supplies of vaccines coming in? It seems like there's a lot more demand than supply, yet surrounding counties have excess.
You know, all along we've hoped for more vaccine, and we keep waiting for the day that there's enough vaccine that it's not considered scarce. We're still, as I mentioned earlier, receiving about the same number of doses. I think there were times that with that number of doses, it was very difficult to get an appointment. But now, as I mentioned, there are some openings in that and more increased availability of appointments. So, and especially with Johnson & Johnson coming back, I think that we will have sufficient supply, and we do continue to expect that very soon in the next few weeks, there'll be increased supply.
Thanks, Rachel. So we have another question around that from Jeffrey, who's wondering, what do we do with any remainder that is left over? And why are we still high in numbers and cases in ICU if we have so many vaccines?
So I can speak to the leftover vaccine or extra vaccine. Public health works really closely with all of the providers in Sacramento County, and everyone knows to be very careful, have known from the start to be very careful with this vaccine. Don't take out or thaw more doses than you think you're going to use. If you have short-dated vaccine, they know they need to reach out to us. So I don't think there's a concern that vaccine is going to waste.
All right. And so, when we're talking about those, extra vaccines that Jeffrey had questions about, one of the attendees wants to know, is there a waiting list that Sacramento County has at the end of the day that you call people? So that way any extra vaccines don't go to waste?
We have operated off of a waiting list, but we are having trouble now. As we move down the waiting list, we're finding that most people who've been waiting are able to find an appointment. So I would say if you're on a waiting list anywhere, go to the Sac County website and look at our page that links to all the places that have appointments, because I think that rather than wait, we could get you in, today or tomorrow. There were openings available today. So we would suggest people not wait, that they try to find a place to get a vaccine as soon as is possible.
Got it. And, as we talk about the vaccine supply and the number of cases and some of the stats for Sac County, Mary Lynn is wondering if there's a specific reason why older adults are still lagging in getting the vaccine, even though they were among the first to be able to get access to the vaccine. She's seen that the latest stats show that those 65 plus in the county are only about 30% vaccinated.
I think and I don't know which database they're looking at, but one thing you need to realize is that some of the information that we have might not be complete, because there is a federal program where doses were going directly to pharmacies, and they were tasked with vaccinating long-term care facilities. We don't have all of that information. I think if you look at the more complete data at the CDC level, you'll see that people over the age of 65 have very good vaccination rates.
Got it. So Nanette is wondering if people with natural immunity need to get vaccinated. What tests can determine if someone does have natural immunity?
So that's a little bit of a tricky question. So we all have what we call innate immunity. Everybody does. There are certain barriers initially that any type of infection has to get by in your body. And it doesn't have to be primed with a vaccine. It doesn't need anything. those innate immunity probably does account for some people getting asymptomatic disease and other people getting more severe disease. It also probably accounts for some of the side effects that people get when they get vaccinated. There's no good way to test that, and it's never a good gamble to think that your native immunity is going to control the disease. If somebody thinks they could have had COVID, or they could have, if they were exposed or something like that, and even if they never got sick, there is an antibody test that can be done to determine whether you have antibodies, which would predict that you would be immune to the virus that causes COVID-19. My experience, which is obviously anecdotal, it's not a huge number of people, but a lot of people who said they got sick last winter and were sure they had COVID, not a single one of them has ever been positive when I test them. So, so I think the likelihood that you're going to be antibody positive is relatively low. But if you really want to check, you can ask your physician to order the test and see what comes up.
That's a great kind of next step for folks, Dr. Cohen. And just a reminder to the community that we do have 13 free community testing sites available throughout the county, Monday through Saturday. And you can get tested and just walk up. You don't even need an appointment. And the results are coming in about 48 hours. So don't hesitate to consider getting tested if you have any questions about that.
Just to point out, though, the test for the antibodies is a blood test. It's not the nasal swabs that I think you're talking about, Liz, which is actually to look for active infection, whether it's symptomatic or asymptomatic.
Thank you. And Dr. Cohen, building off of what you just indicated around, you know, folks catching COVID and the possibility of that, Christina is wondering, what is the possibility of her catching COVID if she's already been vaccinated?
Yeah, it's really, really small. And the further out from vaccine, the less likely. So the best data that are available are actually from Israel. And by 2 weeks after the second vaccine dose, the number of people who are infected are single digits, even given the large hundreds of thousands of people that started in their analysis. So it's really small. We have seen a couple of employees at UC Davis who have been infected, who have been vaccinated. But I can only think of a couple. And the majority of people who are still getting infected within our health system are people who have not been vaccinated. So risk is not zero, but it's really, really small. And once you're a couple weeks out of the second dose of the vaccine with Pfizer or Moderna, or a couple weeks out of the J&J 1 dose, your risk is, I would, again, under 1%, probably under 0.1%.
Got it. And my understanding is that Sacramento County is going to be adding a section to its public health dashboard, which is going to talk about those breakthrough cases. So we'll be able to pull that up for Sacramento County soon on this dashboard that we pulled up at the beginning of the session. So how long will vaccine immunity last? Martha's heard that it's 6 months. This kind of brings back to some of the questions that community members have around booster shots.
Yeah, so we know at least 6 months. That's what we do know already. And I just want to remind everybody that the Pfizer vaccine was approved for use emergently in December, right? So it's only been 4.5 to 5 months ago that the vaccine was approved. The clinical trials went back a number of months before that. So we don't have really long-term data. But what we do know is, for example, the Pfizer vaccine, when it was initially submitted to the FDA, was about 94% effective in preventing infection. In a press release, not in a publication, but in a press release, I think several days ago, they looked at their data out to 6 months and it was now 91.3% effective. So there was a little bit of a drop off, but not much. There have been studies with the Moderna vaccine looking at antibodies, and they really don't drop at 6 months. So just like we don't know how long immunity lasts after somebody gets natural infection, because we've only been seeing infections for a year, that 6 month mark is just because that's when the data collection ends. It's not going to be 6 months. It's going to be longer than that. And regarding booster shots, I think that part of that is going to depend on how much the variants spread within the community. And if there are variants that are not very effectively controlled with the vaccine, that's when the boosters are going to have to come out. And that's part of the argument for getting people vaccinated sooner, because the less infections, the less mutation, the less variants, and the less chance that our vaccines are going to become less effective, and that we will all have to line up for a booster in a shorter time period. I'm pretty optimistic about this, maybe more optimistic than some of the people who have been talking about this nationally. I'm not thinking that we're going to need a booster within the next year. I may be wrong, but I don't think that's going to happen.
Well, let's talk about that optimism. And let's talk to the community a little bit about what they can do to help their community get into the next year. Because one of our attendees is really interested in this. They want to help Sac County's numbers diminish to the next tier. What can we do?
Okay, no one wants that. You want that, Dr. Kasirye? Go for it.
Sure. I was trying to unmute, but I was pressing the wrong button. So I think what we all can do as a community is what we've been doing all along. We still have guidance out. Use a face covering when you're going in public. Good hand washing. If you're sick, stay home and avoid large gatherings. And of course, 6 feet separation from people who are not part of your household. Those are all things that each of us can do individually. And then, of course, the vaccination as well. I think we've talked about this several times, where we have said that vaccines are, the light at the end of the tunnel. But so far, for Sacramento County, I think we're just below 50% of our residents have gotten at least 1 dose. So there's still a lot of work for us to do. If you yourself are vaccinated, you can help us by encouraging people around you that have not gotten vaccinated yet, and encourage them to go and get vaccinated. You can also assist us if you want to sign up as a volunteer and help at some of the sites that we have. I think those are the main things. I don't know if Rachel or Dr. Cohen have anything else they want to add.
Those sound like some great action items for folks to take away. Thank you for that. So let's move over to schools. And young people's access to the vaccine. When will 14-year-olds be eligible to get the vaccine?
So I think Pfizer is just about finishing up their clinical trial in 12-year-olds to 16, and Moderna also. So hopefully they'll be able to bring things to the FDA in the next several months. You know, one of the things that I think is tricky for people to understand is the way vaccine trials are done. You have to have a number of people who end up getting the infection in order to determine whether the vaccine works, right? So in your placebo arm, you have to get a certain number of people infected. And then you can say, this is the difference between what we saw in the vaccine arm and what we saw in the placebo. And that's how you calculate what percentage of protection you see. In a period where the number of new infections are not happening as quickly as they were in December, it's a lot slower accumulating cases to be able to determine whether the vaccine actually works. And that's why some of the trials really went pretty fast at the beginning. And it made people nervous that it was faster than any other vaccine trial, but it was happening right in the middle of the peak of a pandemic. This is going to be a little bit slower in the accrual of cases, and it may take a little longer than we would think, but I think the goal is a couple of months where they can start bringing the tween and teen kids in.
Great. And in the interim, we do have kiddos that are heading back to school. And so Carla is wondering, why are Sacramento County school districts requiring children to wear masks when masks have been proven ineffective by numerous doctors in a recent Stanford study? More than half of the country's schools are open, and some have never closed and never required a mask.
What we have found with the schools that have opened is that when they follow the protocols, which mask is just one part of the protocols, but 6 feet separation between the students, making sure that you're able to screen in people and students or staff that have symptoms do not come in to the school grounds, and also good hand washing. All of these together are what are able to provide the protection. And so in settings where those protocols have been followed, the number of cases has been very low.
You know, one other thing I will point out, just in relationship to this Stanford study, is I'm not sure which one you're alluding to, but there's at least one study that where Stanford said the guy doesn't work there, and the article is actually being withdrawn. And this is a paper that was in a journal called Medical Hypotheses, and they again, Stanford says he don't work there, and everybody that works at Stanford says they don't know who he is. So there's some bogus science floating around too. You know, I hate the idea that you have to say stuff like that, because then people wonder about other studies. But this happened, I think, for those who are on this call, I think everyone is aware of the same issue that occurred years and years ago with the link of autism and the MMR vaccine, where the person who presumably did the study actually faked the data and lost his license in Great Britain. And retractions don't work as well as the original study, sticks much better in people's minds than the retractions do. But at least there may be other studies that I'm not aware of, but at least this one from this guy from Stanford is not a guy from Stanford. And I don't know what the quality of the study was.
Thank you. I appreciate that community members can come here and bring that information and check it by the great team of public health leadership to see what might be correct, what might be incorrect. So moving off of the thread and continuing on the thread of youth, what is the current cohort size for youth day camps?
I don't have that guidance in front of me. We do keep up with the state has been putting out guidance on a regular basis. And so the best thing is to either check our website or check the state website for specific guidance for each situation and sector.
Great. Can water slides and inflatables that go in the water at public pools still go in the water at public pools?
I'm not sure what the question is.
I think this person is interested in their water slides and their inflatables and wanting to know whether they can still be used in the water at public pools safely.
For those that are open, it should be okay. Again, my advice is, I know that the state has released several iterations and changes lately, guidance for different situations. So start with either our website for the guidance, and if someone could find that website and put it in the chat, or the state guidance as well.
I've been reading that some people are skipping their second shot. What are your thoughts on that?
I think that's not a particularly good idea. Again, the data on the protection with the 2-dose vaccines means that you need to get 2 doses. And I don't think people should feel confident that they optimally got vaccinated if they don't get 2 doses.
And we were recently asked that question, and I think just looking at our data, it did seem that the majority of people do get their second dose. And maybe Rachel, do you want to add anything to that?
Sure. Sorry, I was answering a question. Yeah, I think we're seeing a good rate of return at the sites that we were operating, and when we did look at the data preliminary, it looks like most people are not only getting their second dose, but they're getting it pretty close to on time. So, and again, I would just echo that it's really important to get that second dose. If you're having trouble finding a second dose, you can email COVID-19 vaccine@saccounty.net. And we can connect you with a resource to make sure you get the right second dose, because we want you, if you got Moderna, we want you to get Moderna. If you had Pfizer, we would like you to get Pfizer.
What impacts, positive and negative, have we had in the administration by Blue Shield?
I think that's a loaded question. I think what I can say is that having to shift our strategies and protocols in the middle or midstream has not been easy, because we were already in the process of rolling out the vaccine, and we're working with the state, with CDPH on it. And so by bringing in a Blue Shield, we had to change a lot of those processes that we were working on. And that is never easy, especially when you're dealing with a pandemic. And also, of course, having a lot of questions about what's, concerns about making sure that our providers know what they need to do, and making sure that they get the right connections, get the contracts, and contracts are not an easy process either. So it was a shift and a change in the way that we do business. And of course, Rachel has had more hands-on with that, but I think at least what I saw is that I think the way that we work in public health is very relation-based. So we were very accustomed to, and Rachel was doing most of this, keeping a close eye on our providers and interacting with them on a daily basis and finding out what their needs were, and being able to move vaccine around. And of course, that is not as easy if you're having to deal with someone else who's supposed to do that part. And I think the way that Blue Shield operates is a lot more automated. So it does make it more difficult when issues do come up. So I don't know, Rachel, if you have anything you want to add.
Sure, yeah, just like you said, it's been challenging, definitely a big change for us. It was really fantastic to get to know the providers so well here in Sacramento County, and but it was also very time consuming to work through the allocation process. So hopefully when the transition is complete, that piece will be less time consuming on our end, because Blue Shield is doing more of that, and that will free us up to really be able to get back to the work that is so important, which is getting out into the community. But also we are continuing to keep the relationship that we have with our providers, even though we're not doing the allocating anymore. We do have a weekly call with them, update call, where we can really talk about, and hear from them as well, what's going well, what's not working. We share any updates, clinical updates with them. And then we send a provider bulletin once a week too. So we're going to continue that strong relationship that we have with our Sacramento providers and the health systems. But hopefully be less in the weeds, so to speak, with the process of allocating.
All righty, thank you. We have two questions around what is the difference between a first dose and a second dose? Is the second dose stronger than the first one? Are they different formulas from one another?
No, it's the same vaccine, first and second dose. The reason that people tend to have more local side effects with the second dose is because their immune system has already been primed by the first dose. That's why there's a difference in the side effect profile. The vaccines are exactly the same.
Got it. And so, Rachel, I know you talked about the allocations at the top of the meeting, and we talked about the Johnson & Johnson change, and Allegra is wondering if they can get Johnson & Johnson available in Sacramento now.
Yes, I think you'll start to see it again in community pop-ups. We certainly plan on having it available at some of the pop-ups that we're doing. And then there are quite a few providers and health systems that have Johnson & Johnson that had it already, even though we were given no doses this week. If you'll recall, a couple of weeks ago, we did get an allocation. And then as soon as it arrived, we put it on pause. So we have those doses ready to go. Again, we want to be really methodical and make sure that we're have all of the information for providers and for patients to make a really informed choice about which vaccine, if Johnson & Johnson is right for them, or whether another vaccine is a better option. So, but I think you'll start to see it available again, even in pharmacies too.
Great. And another question about the Johnson & Johnson. Has there been any correlation determined between the Johnson & Johnson vaccine and women on oral contraceptives?
The answer to that, to my knowledge, is no. So the kind of clots that women get when they're taking oral contraceptives are totally different than this clotting syndrome that's been seen with the J&J vaccine. So at least to my knowledge, unless somebody knows something differently, there's no correlation between people taking oral contraceptives or even people who've had clots after taking oral contraceptives and getting the J&J vaccine.
In terms of contact tracing, what are we currently seeing as the major sources of spread?
We're not seeing any major outbreaks. We are seeing some small outbreaks that are related to school sports and also school reopenings. But once those outbreaks are identified and you have the students quarantine, it usually puts an end to the spread. Most of what we're seeing is community spread. It's not really related to any specific setting.
Are vaccinations going to be mandated for shelters and schools?
At this time, we do not have any information on that. I have not heard of any plan to do that.
Why do certain counties in the San Joaquin Valley and in SoCal that had higher rates than Sacramento County now have less restrictive levels that they're in than Sacramento County, according to a TV news report that this person heard recently?
Yeah, those are good questions. And of course, we've been looking at the data and trying to figure out, sometimes it's difficult to know why there are differences regionally. I can speak to why I'm thinking that Sacramento County went into this plateau. I think there were several reasons. One being that, again, as we started having more school sports, we did see a slight increase in that age group. And then also we have heard from the state that there is more of a variance in circulating within California, B117, which is from the UK, which is known to be more infectious. Of course, we do not do sequencing on every single specimen, so we don't know just how fast spread that is, but we expect that that is probably a factor. And then also when you look at some other factors, for example, counties where they are able to do high volume of testing, especially if they have a university, they tend to be at an advantage in terms of being able to drive their positivity and case rates lower just because of the volume that they're able to do. And then lastly, also when you look at our vaccination rates, I think several times we had stated that Sacramento at the beginning was at a disadvantage because as we rolled out the vaccine and started with occupation-based vaccinations, Sacramento being a major hub for vaccine, we were having a lot of people who work in Sacramento but live in neighboring counties getting vaccinated here. So about 20% of our vaccines were for people who are in that category. And when they changed the formula to account for those in the agricultural sector, areas like the San Joaquin Valley got a larger percentage of the vaccinations. But now that it's gone to population-based, I think we don't have those variabilities. And so we're hoping that, especially as we continue with our efforts and continue vaccinating, that we will not lag behind anymore with the vaccinations or with the case rates. And as I mentioned at the beginning, we are seeing that the case counts have dropped, and we're hoping that that will be an ongoing trend.
Thank you. So we have a community member that wants to know what is their risk, or what is the risk for a vaccinated immunosuppressed person to catch COVID? My spouse uses methotrexate for RA. Is there an antibody test for immunocompromised people? Do you recommend definitely continuing to wear a mask?
Yeah, so these are great questions, and there actually are a lot of studies that are being done to start looking at some of the immune compromised patients. I know that the Leukemia Lymphoma Society in the United States has a large cohort of people that they're following and doing antibody testing and doing other tests of their immunity after they've been vaccinated. I have been doing this with our bone marrow transplant patients and with our kidney transplant patients, even though there's no clear recommendation to do it. I think if somebody wants to see whether they have antibodies, the tests are available. Again, it's a blood test. Most of them don't give you a titer, which is the amount of antibody in your blood. It just tells you whether you're positive or negative. And so you may not be totally protected if it's positive, but you know you don't have immunity if it's negative, or at least as we understand immunity right now. So that may be helpful. And I think until you know, I think wearing masks is the right thing to do.
All right. Are the outbreaks at schools identified due to symptomatic kids, or just the extra testing is being required for certain sports?
In most of these cases, it's children that have mild symptoms.
At what tier do we get to go back to the Board of Supervisors in City Hall in person?
Right now, actually, we are able to do that, but the Board of Supervisors staff are working through the logistics of how that's going to happen because, of course, we still have a masking mandate. And so figuring out how that is going to be enforced as well as what the capacity for the chambers will be. So I believe that there will be an announcement sometime soon as to when they'll be able to allow the public to be in person.
Okay, so how high are the respiratory risk factors? What are alternatives and preventative measures? And these questions are in regards to the vaccine.
Oops, I had a problem unmuting. So I think that if you ask what are the respiratory risk factors for getting COVID or getting more severe disease with COVID, I think there's even some debate about asthma, but asthma seems to be associated with more severe disease. If you have underlying lung disease, that increases your risk. It doesn't increase your risk of having a side effect with the vaccine. And so I think it's important to, and even more important for people who have underlying lung disease to actually get vaccinated. And the same person asked a question about undergoing cancer treatment. And that's sort of the same story that I brought up with the immunosuppressed people. I just clicked the wrong thing instead of typing my answer, I said I'd answer it live, but it's basically the same idea. So somebody who's undergone cancer chemotherapy is immunosuppressed, at least while they're on the chemotherapy. And, we'd like to wait sometimes. This is one of the circumstances where we actually wait to give vaccines until we see some semblance of the immune system coming back again. For example, in bone marrow transplant patients, we wait a while because we know that if we give it early, as much as we'd like to, that it's not going to do anything. And so you've got to be able to determine that the person's going to be able to generate a response.
Got it. And it seems like when you started to talk about the variant, Dr. K, some folks had some questions about that. So would you expect younger ages to be affected by this variant? And when would Sac County decide to do more sequencing?
So the capacity to do sequencing is really based on resources. Right now, we have to send the specimens to the state. We're not doing it in our lab. We're hoping that we will get that capability up and running soon. But also the state does have criteria for when they decide to do the sequencing. And that includes if somebody has been vaccinated and then they get COVID-19 symptoms and they're positive, they will do the sequencing in that situation. Or also if there are other factors such as travel that increase the risk that this person might have a variant. So we're not doing it with all of our specimens. There are some university labs that are doing it on select specimens for surveillance. And so again, we don't have the capacity to do it on every single one of the specimens that we get. As far as which age groups, I don't think that that any of the variants have been selective on age groups. I don't know if Dr. Cohen has any more information on that, but what I'm hearing is that, especially for some of them that are more contagious, it's regardless of the age group.
Absolutely. That's absolutely true. It's there's no age preference, right? Whether they get disease is still going to be age dependent, at least in part, but not whether they get infected.
Got it. So we'll take two more questions here. So we have a community member that wants to know, when will the vaccines receive full FDA approval?
Yeah, I don't know. I can't even hazard a guess. Sorry.
Okay. And the conversation on social media can be really scary, related to the safety of the vaccines. Can you speak to the safety of the vaccines, particularly thoughts on long-term safety?
Yeah, so this is a very difficult question to address. But I want to put some things in context. First off, let's avoid talking about the vaccine for a second and think about what happens in people who get COVID and how every facility has now a clinic for long-term COVID patients, people who have never recovered. So that's first. If you get COVID, there's a significant chance that you will be impacted for much longer than the illness itself. That's number one. Number two, just as I answered the question relating to antibodies, because we don't have data beyond 6 or 8 months for most people who've received vaccine, we can't really talk about long-term vaccine effects. But we know that within that time period, nothing new has popped up from the beginning to now 6 to 8 months, right? This blood clotting thing with the J&J vaccine happens after about 6 or 7 weeks. So that's as late as we've seen any side effects popping up. And there's no evidence with any other vaccine that I'm aware of, unless Dr. Kasirye can correct me, where if you don't get some kind of side effect at the beginning, you end up 2 years later having a problem. So I just don't see this as being an issue regarding long-term complications. And again, when the balance is weighed, the chances of getting long-term complications with COVID is quite significant.
Great, thank you, Dr. Cohen. So those are all the questions we'll take for tonight. I did send out the COVID-19 email address that folks can email. If you're calling in, it is COVID-19 vaccine@saccounty.net. Dr. K, Rachel, and Dr. Cohen, any final thoughts for the community tonight?
Just encouraging everyone to get vaccinated if you have not done that yet.
Yeah, I really appreciate these forums. I think the questions that we get are terrific. I hope people remain interested, and I won't reiterate what Dr. Kasirye has said because it's self-evident that we all want everyone to get vaccinated.
All right, Rachel, anything from you? Okay.
Thanks for having me.
All righty. Thanks, everybody. Have a great night.